Hi, this is the third in a series of conversations about death and dying in America and our attitudes. And in this one, I would like to focus on how you can legally make your wishes known so that you don't become Terry Schiavo or a Karen Ann Quinlan. If you remember either of those cases, they were both young women who courts and family members could not decide could not agree on what their wishes might have been, so they were both maintained in persistent vegetative states for 10 years until they died. And so there are, in California, we have two options, which is really nice. And I downloaded copies of both of these off the internet. And one is a durable power of attorney for health care, for example, also known as a living will. And those can be filled out. Lots of people fill them out when they make their wills. And you can also fill it out separate from that. And the first thing that you do is you designate an agent. If you're unable to speak for yourself, when I was a nurse, and we're required, actually, hospitals are required to ask for a copy from everyone who walks in the door. Do you have a durable power of attorney for healthcare? Could you please bring us a copy? It makes life much easier. If you have a copy, you know that person's wishes. And the first thing you do in this is you designate an agent, the person who's going to make decisions if you are incapable. And I would always give the example of if you drove into a tree and you came into our trauma center, who would be making those healthcare decisions if you were found to be profoundly brain damaged or whatever. And in my case, I designated my husband. Now, if you're an elderly person and your spouse is also elderly and you want to designate them as the person to make those decisions, make sure to designate a secondary or a tertiary person who could make those decisions if your spouse became unable or unwilling to make those decisions, and make sure that those other people also know what your decisions would be. The agent's allowed to make all healthcare decisions for you, and you have an opportunity to say accept, and you can fill in the blank, accept blah blah blah. You can also designate when that agent's authority becomes effective. Either, like for me, for a young person, it's when I become unable to make those decisions for myself. Or if you're an older person, and I've known a lot of older people who have trouble making any kinds of decisions, and they might want to make that effective immediately. We would ask patients, on a 1 to 10 scale for pain, what is your pain level? And some older women would say, I don't know, what do you think? And, those kind of people might want to designate someone right now to make those decisions for them. Then it has end of life decisions, and this is where you can choose not to prolong life, commonly known as a do not resuscitate, or I prefer the term allow natural death. With medicine these days, we can maintain life for amazing lengths of time. Your limbs can die one by one, and we can still maintain your life. And so you can choose to allow natural death, or you can choose to prolong life. And if that's your philosophy, for religious reasons or whatever, that you feel that you need to be maintained as long as possible, that's all right. You can make that choice too. And then you have something called other wishes. For example, I had a friend who she had respiratory failure, and her son found her in respiratory failure on the floor at home, called 911. She went to the hospital, ICU. It was a dreadful experience, and she told her son, you know, if that ever happens again, you come home and you find me, just take yourself to the movies. And on there, she might put herself as a do not resuscitate. But if she were still alive when she came in, she might put under other wishes, do not intubate, do not send me to the ICU, and that kind of thing. And then you also have an option to be an organ donor. You sign it, and then witnesses sign it. The witnesses cannot be your power of attorney. They cannot be an employee of the hospital. They cannot be someone who's going to inherit, if going to be in your will. Therefore, acquaintances, or if you're in a skilled nursing facility, then they do have ombudsman, I believe is the term, who can witness it and make it legal. Now, the one thing about the durable power of attorney for healthcare is it indicates your wishes. It is not in and of itself a legal document that is honored in a hospital. You have to tell, that's why hospitals ask you to bring it. And then the doctor has to write an order that says do not resuscitate. Now, the problem exists when a person is in a skilled nursing facility, middle of the night, comes to the hospital because of pneumonia or high blood sugar out of control, something like that, and they are unable to give us any information about themselves. And due to Health Information Privacy Act, we might not be able to get much information from the skilled nursing facility, and we don't know that they have a durable power of attorney for health care. And we might not find out for a few days until the family members finally call. So, and it also, interestingly enough, the doctor would then have to write the do not resuscitate order if that was the person's choice or whatever. And interestingly enough, if they're then being transported back to the skilled nursing facility, the ambulance would need an additional order written just for the ambulance ride. Now, California has something that I think is absolutely fabulous. And I don't know if other states have this. Normally it's in a hot pink form. It's called a POLST, P-O-L-S-T, Physician Orders for Life-Sustaining Treatment. And it is just very succinct, and it's signed by a physician, and it is good everywhere. You have a copy in the skilled nursing facility. Copy goes with you to the hospital. You're immediately, if that was your choice, you're immediately a do not resuscitate. I have one of these filled out, and I keep it in my purse. And what it contains is, first thing it talks about is cardiopulmonary resuscitation, commonly known as CPR. If you're not breathing and you have no pulse, do you want them to perform CPR on you? And you have two boxes: attempt it or do not attempt it. And do not attempt resuscitation is commonly abbreviated DNR, do not resuscitate, but I prefer the term allow natural death. Then it has a section for medical information, interventions, comfort measures only, limited interventions, and full treatment. And for example, the limited interventions, my woman friend who had the respiratory failure, maybe if she was admitted to the hospital, she might be willing to take antibiotics, but she could say, I don't want to go to an ICU, I don't want to be intubated. And then this section is called artificially administered nutrition, and this is also very good. It gives you 3 boxes. One is no artificially administered nutrition. One is a limited time period for artificially administered nutrition, and one is long-term. And for example, a person who has a stroke is a very likely candidate for artificial nutrition because immediately after a stroke, they might have difficulty swallowing. They can't feel, and so they can't direct it down the right tube, and they aspirate, they get pneumonia. As long as the person has enough coherence to be able to follow instructions, then they can be taught techniques for how to swallow, and maybe by, holding their chin down, directing the food with their tongue, or using thickened liquids only. They can be taught how to safely swallow. And they might have tube feeding for a period of time, tube feeding through the nose for a period of time until they can be safely taught how to swallow. If, however, a person has an utterly debilitating stroke, they would need long-term tube feeding, which would be inserted through their abdomen directly into their stomach. So you have choices there for whether you don't want that to happen, do want that to happen, or just a limited trial if it doesn't work after a limited period of time. And as I say, this is good wherever you go, and California is way ahead of itself there, I think, in that regard, because I think that's just an absolutely wonderful document, and more people should know about these. Now, one thing I want to mention is doctors don't necessarily feel comfortable bringing up the subject of do not resuscitate or resuscitate. And so therefore, it is our responsibility to bring that up. Part of the problem is doctors are too rushed. They don't have time to develop personal relationships. Your personal physician doesn't follow you in the hospital. You're admitted to a hospital, you have a hospitalist who doesn't know you, doesn't have a relationship with you. So I think that's something that you have to bring up with your physician. Also, our physicians are from different countries now, and there are a lot of Asians, a lot of Indians, Persians, and they may not feel comfortable bringing that subject up with someone from a different culture, or that might not be comfortable in their own culture. They're not, necessarily hand holders. So you have to bring up that subject with your physician. And I think that will do it for now. And I hope you have a thoughtful day.